Good afternoon, ladies and gentlemen. My name's Gus Nossal, and it's my great honour to be your chairman for this afternoon. I'd like to begin by acknowledging the traditional owners and custodians of the land on which we meet today, the Wurundjeri people of the Kulin Nation, and to pay my respects to their elders, past and present, and to any other elders from other communities who may be here today. Now, I've got a few reminders for you. This event is being live streamed and tweeted using hashtag WeHi100. It's being filmed and will be available on the Institute's website, and therefore please be kind enough to turn your mobile phones to silent or off. In the event of an emergency, follow the instructions of the wardens, who will be omnipresent. Presentations will run for approximately 30 minutes, and the rest of the hour will be the opportunity for you to ask questions of the panel. Now, this is one of a number of events celebrating the centenary of the Walter and Eliza Hall Institute of Medical Research. Yes, the Institute was born as a child initially of the Melbourne Hospital, the Royal Melbourne Hospital, and the University of Melbourne in April 1915. And the first director designate was Gordon Clunes Mackay Matheson, a quite brilliant 32-year-old Australian who was at that time serving in the armed forces and at Gallipoli. Most unfortunately, he was wounded by a stray bullet, died in May of 1915, and therefore was never able to assume his directorship. In the event, the powers that be said, well, we've got this lovely space here as one floor of the pathology department of the Melbourne Hospital, now Royal Melbourne Hospital. Let's give it over to Commonwealth Serum Laboratories, now CSL, and there was born that great partnership which exists to this day. Now, one of the areas that the Hall Institute is most famous for is the study of the natural immune defence system of the body, the discipline we call immunology. That is, of course, an absolutely vital system which guards us against infectious diseases and which has given us the precious gift of vaccines, which have so markedly lowered infant mortality right around the world. But one thing that people don't often think about is that this delicate immune system can go wrong, badly wrong. That's the field we term immunopathology, and that is, in point of fact, the burden of our afternoon today. Maybe the most, the most difficult to comprehend in some ways is the autoimmune diseases. That is a situation where these white cells of the blood that are supposed to guard you against viruses and bacteria turn traitorous and begin to attack organs of the body. We were very early into this field. We, in point of fact, started working this field in the mid-1950s, and you would not believe the difficulty that we had persuading clinicians that autoimmunity was a reality, that this wonderful system could turn so badly wrong, and in point of fact, we now know that the autoimmune diseases as a compendium, including juvenile type 1 diabetes, multiple sclerosis, rheumatoid arthritis, systemic lupus, a variety of other diseases, much of thyroid disease, much of endocrine disease generally, together constitute an enormous public health problem. The immune system also fails. You've all heard of AIDS. Now, what does AIDS mean? AIDS is the acquired immune deficiency syndrome because a virus has come and wrecked the immune system. But of course, long before that, we knew about the congenital immune deficiencies, hence the word acquired, as opposed to the congenital ones, such as agammaglobulinemia, and we'll be learning more about that today. And finally, unfortunately, this great system sometimes responds inappropriately. Then we get allergy, or, as in the fascinating disease that you're going to hear about, celiac disease, it responds to gluten in the diet quite inappropriately, makes antibodies when we shouldn't be doing so. So that's a fascinating story, and it will be unravelled comprehensively for you. But I've got one deep request for you. We're not going to have time to have questions after every talk. So please, for the exciting discussion period that we'll have in about 40 minutes' time, please don't direct all the questions to the last third of the last talk, because that's what so often happens. Take notes or take mental notes, have as many questions for the first speaker as for the last speaker. They're leaders in their fields, and I'm delighted to introduce them one by one. Our first speaker tonight is Dr. Jason Tye-Din. He's a gastroenterologist and clinician researcher who heads the Institute's Celiac Disease Research Laboratory. In addition to his involvement in the clinical care of patients with celiac disease, Dr. Tye-Din and his research team have helped characterise the immune response to gluten, and that's underpinned the design of improved diagnostics and, hopefully, treatments. This includes a vaccine for celiac disease that will help reintroduce gluten into the diets of people with celiac disease currently in clinical trials. So, Jason, please come and give us your presentation.
Thank you very much for that warm introduction, Gus. So welcome everyone, and it's a real pleasure to be talking to you today about celiac disease research and future treatments. Before I start, I should just draw your attention to a disclosure I'd like to make that I am a consultant for a biotech company called Immunodeficiencies based in the United States that is leading the development of the celiac immunotherapy, and I'll touch on that tonight. And I'm an inventor on patents related to the use of gluten peptides, which will be hopefully used in diagnostics and therapeutics. So I think that it'd be fair to say that most people are aware of the gluten-free section in their supermarket now, the gluten-free options on their menu. And I think that many people probably think that going gluten-free for people with celiac disease is a bit of a lifestyle decision, and that perhaps it's a little bit of a fad illness. And it couldn't be anything further from the truth. We now appreciate that celiac disease affects 1 in 70 Australians, so this makes it the most common autoimmune disease affecting humankind, twice as common as type 1 diabetes. We know that gluten, which is a protein found in wheat, rye, barley, and to a lesser extent oats, drives this abnormal immune response that causes intestinal damage. And you can see the picture on the top right of the slide there showing the normal intestine, the long finger-like villi that help absorb nutrients, and on the far right, flattened, inflamed villi, which are damaged and cannot absorb nutrients. And that's one of the hallmarks of celiac disease. We know that certain genes are very important in imparting susceptibility to celiac disease, and this is because they have an effect on the immune system. And there's also poorly described environmental factors that are important in triggering people who have the susceptibility to celiac disease. And the picture here is of some bacteria, because there's emerging very interesting research now that suggests that the microbiome, the bacteria you have in your colon, particularly during early infancy, plays a very large role in the development of celiac disease and probably other immune and allergy-based diseases. Now, we know that celiac disease, the only treatment is a lifelong and strict gluten-free diet, which is complex, it's costly and onerous, and as you'll hear later, it doesn't work fully in everyone to lead to healing of the gut. So while it's the only treatment we have, it's certainly not the optimal one. We know that celiac disease has a range of symptoms, which I'll touch on in a moment, but what often isn't appreciated is the substantial impact it has on quality of life, and it really can cause impaired quality of life, and it even leads to a doubling of mortality due to increased cancer risk and increased risk of infection. So these pictures here really show a young child with bloated tummy. You can see some of the ribs poking through. This is a very malnourished child, and celiac disease, because it does present with bowel damage, has always traditionally been characterised as a bowel condition where malabsorption is a problem. And so gastrointestinal symptoms, bloating, diarrhoea, abdominal pain, wind or lethargy and fatigue, low iron levels causing anemia or failure to thrive in children have been the predominant types of symptoms it can present with. Now, you would be sort of mistaken to think that this was actually a picture from maybe the 1960s from a medical textbook, and indeed a lot of the old medical textbooks showed these kinds of pictures, but this was actually passed on to our research group by a volunteer, the mum of this 18-month-old child only a few months ago, And this is a child who had been taken by the mother to 3 different general practitioners who reassured the mother not to worry about things. As it turned out, clearly, something's wrong. This child has celiac disease and is now doing very well, having been diagnosed and on a gluten-free diet. Now, the genetics and the immunology of celiac disease is now starting to unravel, and I'll touch on that in a short moment. But what this is really telling us now, that it's no longer just a bowel disease. What it is an autoimmune disease that affects all ages. It has many effects, not just to the bowel, and in fact, many people have no bowel symptoms and can present with what we call extraintestinal symptoms, so migraines, infertility, osteoporosis, lymphoma, neutropenia even, and a whole range of other autoimmune conditions, which I'll touch on as well. So this is the kind of face of celiac disease now. It's a global condition. The most common frequency of celiac disease is actually in Northern Africa. We used to think it was a Celtic disease. So a lot of these myths are now changing with new research really highlighting how common it is. Now, this slide really links all of the common disease associations seen in celiac disease that clinicians such as myself are aware of when we review patients in clinic. Now, you can see that this is not an exhaustive list either, but there's multiple bodily systems affected in celiac disease, the immune system, but also the bone, joints and nerves, the skin, the nervous system, the gastrointestinal tract in other areas. You can see here that Professor Ian Wicks will be talking about lupus shortly, and you'll hear from Dr. Bryant shortly about immunodeficiencies. And IgA deficiency and lupus can be associated with celiac disease. And in many of these cases and many of these diseases, they actually improve in their disease activity when celiac disease is diagnosed and treated. So to put that all together, what are the things that clinicians are facing at the moment that are really important to address? Well, clearly it's a common condition and we know it's on the rise. There's 4-fold rise in the last 50 years. We know that diagnosis is suboptimal. So part of a recent study that I was involved in looking at nearly 3,000 people from Geelong off the electoral roll showed that 1 in 70 Australians had celiac disease, 1 in 60 females, 1 in 80 males. But 80% of those people didn't know they had it when we started the study, and only 20% had been diagnosed through routine clinical practice. So it's a condition that's common, but unfortunately isn't being detected. But on the flip side of the coin is many Australians are already removing gluten from the diet. And this comes back to the popularity of the gluten-free diet, where there's the perception that it is a healthy lifestyle choice, which probably isn't supported by medical evidence. But what happens now is that we need to define those people who really will benefit from a gluten-free diet. One of the problems is going gluten-free means that the current diagnostic tests we use, the screening blood test and the biopsy, are no longer accurate. Finally, the gluten-free diet, as I mentioned before, is a challenging treatment. It's lifelong, it's strict, small amounts of gluten can activate the damage in the gut and lead to those complications that I discussed in the previous slide. So clearly, better diagnostics and treatments for celiac disease are a clinical priority. However, how can we develop those? And the answer to that is clearly we need to understand the mechanism underpinning celiac disease. So when we look at the genetic data, this gives us insights into what's happening. And you can see here that all of these little things in the boxes are various genetic markers that are found in different conditions in celiac disease, other autoimmune diseases such as rheumatoid arthritis or lupus or type 1 diabetes, and in inflammatory conditions such as Crohn's disease of the bowel. And you can see that there's very strong overlap, particularly with the autoimmune diseases. Now, all these genetic markers actually influence how the body's immune system responds in various ways. So the data really strongly says that celiac disease is an immune problem as opposed to an intrinsic problem with the gastrointestinal tract. And so this overlap here is very important in understanding the other clinical correlations that we see in celiac disease. Now, one of the most important gene markers in celiac disease is the HLA genes, particularly something called HLA-DQ2 and DQ8. Now, these are important because these genes code molecules on the surface of particular cells called antigen-presenting cells, and these grab foreign antigens and then present them to T cells to elicit an immune response. And in the case of DQ2 and DQ8, they can pick up various fragments of gluten and then present them to T cells to activate that immune response. So a key question for researchers is to say, well, what are the gluten peptides driving those T cells? Can we identify that those peptides. And this has always been a challenge within the autoimmunity field of understanding the actual antigen driving the illness. The beauty about celiac disease is that we know gluten is the driver, whereas in conditions such as type 1 diabetes, we know that there are probably things within the pancreas that trigger an immune response against the pancreas, but we really haven't delineated them in any great detail. So that was the goal when we set out about early 2000. How do we define this? And the simple answer, which came from pioneering work from my colleague, Dr. Bob Anderson, when he was in Oxford back in sort of 2000, was that you feed people with celiac disease some gluten. And what happens then is that they develop an immune response, which 6 days later, you can actually measure in the bloodstream. So you can see here, this is a special immune assay, and before they've eaten gluten, there's nothing happening there. But on day 6, you can see these spots in these particular wells, which indicate T cells are responding to whatever was in those wells. And in that case, it was specific fragments of gluten. Now, extending this approach over the last 10 years, what we have done is screened hundreds of people with celiac disease eating wheat, rye, barley, or oats, and tested a whole range of different peptides encompassing all of the potential parts of gluten that could be toxic. And these are some of the results. So this is a map of wheat and shows some of the hotspots that drive the inflammation in celiac disease. And we can see here clearly that there is some hotspots that are important. And as a result of this work, we've defined 3 key peptides out of more than 18,000 that are relevant in celiac disease, and this is the basis of so-called NextVax-2, which is now in clinical trials for the treatment of people with celiac disease. This is now advanced to phase 2 trials, which are planned this year, and basically the aim is to induce an immune response that induces tolerance to gluten. So instead of intolerant reaction, tolerance is achieved, and that people can consume a normal diet. Now, this is a slide showing what happens when gluten's consumed. It enters the gastrointestinal tract through the intestine. It comes into contact with these antigen-presenting cells, and if you have the HLA-DQ2 or DQ8, presents it to T cells and activates that immune cascade that leads to the damage seen in celiac disease. So the immune vaccine, the celiac vaccine, is targeting this T cell population here. There are other groups, for instance, up in Queensland, looking at other ways to modulate this immune response, for instance, by infecting people with hookworm. So this is a really interesting study that shows that hookworm infection can actually deviate the immune response away from a pro-inflammatory response to something that causes less damage. And that's a very interesting, intriguing approach. Now, this is not an exhaustive list, but does show other groups working on other approaches that are in quite advanced clinical studies at the moment. So other groups are working on enzymes called glutenases, which can break down the toxic components of gluten. And the aim here is to try to add it to a person's diet to really detoxify small amounts of gluten that may be in the diet. Other approaches include reducing chemicals that are secreted by the gut that increase the leakiness of the bowel. And so these are all in clinical trials, and particularly with the oral enzyme therapies are quite advanced. These have completed phase 2 trials and are showing a lot of promise. Then there's also approaches that use steroids or steroid-like agents to actually help dampen that immune response. But the problem with steroids is traditionally is they do have side effects, so they're not particularly great for long-term use. Now, I should mention that all of these approaches tend to dampen the effect on the immune system, but they're only adjunctive to a gluten-free diet. You have to actually target the underlying gluten-specific T cells if you actually want to cure celiac disease. So these are going to be very promising for the adjunctive treatment of celiac disease, for instance, when people are eating out and may be exposed to gluten, but they're not going to mean a person can come off a gluten-free diet. Now, these are a list of some other projects that we're doing currently within our research group, and in the interest of time, I won't go into exhaustive detail, but basically, we are using NextVax-2 as a way of trying to be very much more specific with detecting the immune response seen in celiac disease, and this could provide another way to diagnose the condition and overcome the need for both a small bowel biopsy and prolonged gluten exposure. The other field that's quite interesting now is genomics, and that's really looking at the whole genetic information within the individual, and we're trying to determine whether if we use more More than just the HLA information, can we develop better scores to enable risk prediction for celiac disease? In other words, who is likely to develop celiac disease? For instance, if you have a first-degree relative with celiac disease, what's your chance of going on to develop it? So there's some promise coming out of that data. We're looking at why do symptoms occur in celiac disease. One of the intriguing things is that 25% of people are sick in celiac disease in the gut and in the bloodstream, but they have no symptoms when they're exposed to gluten. What's the differences? What's the mechanisms? We're looking at that, and can we prevent the terrible symptoms that are akin to food poisoning when people are exposed? And basically, we're looking at oats as well, because oats is a controversial area in celiac disease, and there's a few others there. But for people who are interested in our celiac disease research, there is an email address there that we're happy to provide more information, celiac@wehi.edu.au. So basically, I think it's clear that an understanding of the genetic and immune basis for celiac disease has really enabled us to understand what's happening in the immune response to gluten and opening up new ways to diagnose and potentially treat the condition. And I should throw in now that there's really a lot of emerging interest in understanding how the microbiome and the early infant environment is impacting on the development of celiac disease and more broadly other conditions like allergy. So I'm going to stop there. These are some acknowledgements of collaborators and funders, and I look forward to your questions at the panel later. Thanks for your attention.
Thanks very much, Jason, for that brilliant and beautifully illustrated talk. And remember, questions at the end. It's now my great pleasure to introduce Professor Ian Wicks, who is going to talk to us about lots of things. Ian is the Director of the Rheumatology Unit at Melbourne Health, which is a leading centre of excellence in patient care, teaching, training and research in rheumatology. He's also head at the same time of the Inflammation Division of the Walter and Eliza Hall Institute. His division researches immune conditions that include lupus, rheumatoid arthritis and rheumatic fever, with the goal of improving diagnosis and treatment. Soccer to him, Ian.
So I think we're on. So thanks very much, Gus, and it's great to see the room jam-packed, and it's obviously a series of talks that have generated a lot of interest. So I'm going to talk about this fascinating disease called systemic lupus erythematosus, or SLE, or lupus for short. Lupus is a Latin term that means the wolf, and this is shrouded in a little bit of mystery in terms of medical history as to why it was used. This is actually a patient here with a classic facial rash of lupus, and you can see the similarity with the facial appearance of this sinister-looking wolf. In some of the textbooks, the rationale for the use of the name is that there's the bite of a wolf leads to a very scarring skin reaction. So that's another explanation for the name. Perhaps a less sinister image over here on the left of the butterfly, looking once again like the distribution of this rash across the cheeks here, so the so-called butterfly rash of lupus. This nicer, in many ways, image has been picked up and used in various campaigns around the world to increase awareness of lupus. So I'm going to try to do the impossible, which is to talk about this very complex, fascinating condition in a brief period of time, to give you some sense of what the disease is and how it affects people, how we manage it, what's going on with current research, and what the future might hold. So what is this condition, SLE or lupus? So it's very much a multi-system disease. It's thought to have an autoimmune basis, and similar to what you've been hearing about this evening. It has a very wide spectrum of severity. So there are patients with mild disease, and patients with life-threatening disease and who may actually succumb and die from lupus. It's relatively uncommon. So compared to what Jason was just telling you about with celiac disease, the prevalence of lupus is probably around 1 in 1,000, although that varies according to the ethnic group. So there are some racial groups where it's much more common than 1 in 1,000. And it also seems to be becoming more common, probably as a result of better diagnostics. Now, it's overwhelmingly a female disease, so the ratio of females to males is around 9 to 1, and most of the patients are actually in their early adult years, so very much in the prime of life. So, to give you some feel for the clinical problems that arise, this is the classic malar rash or butterfly facial rash of lupus. It tends to occur in sun-exposed areas, and photosensitivity, dramatic photosensitivity is shown in this photograph. The rash tends to be scarring, so this is a patient with discoid lupus that's scarring. It does affect males, so here's our token male here. I think this person's reasonably famous from reality TV shows. So just to show you, it does occur in males, but it is much less common. Alopecia or hair loss can occur, although rarely leading to baldness, but it can cause this thinning of the hair and mouth holes. This is another very common complaint. Now, in the early days, lupus was very much considered as a dermatological disease, so physicians in the 1800s would recognise those clinical appearances in the skin. But as time went by, and with the turn of the century, and new tools and reagents and perspectives on pathology, it became clear that this is very much a systemic disease. And the number of systemic manifestations has just continued to grow and grow over the years. Some of the more common things are various forms of reduced blood counts, low platelet count, for example. The cardiac and respiratory systems are commonly involved, so presentations such as pericarditis or pleurisy are very common. Blood vessels can be inflamed as well as joints. But two of the most feared complications are when major internal organs such as the kidneys or the brain become involved with lupus. This is a picture of a glomerulus in the kidney, which is the filtration module in the kidney that filters the blood and produces urine, showing the nice clear spaces here for that filtration to occur. This is a kidney affected by lupus, where the architecture is completely distorted and the kidney is packed with inflammatory cells. That person will develop symptoms, could go on to have renal failure. Here is an MRI of the brain. And neurological manifestations of lupus are increasingly appreciated as a key part of the condition. So in many patients, this is headaches, depression, anxiety, but it can be much more serious with stroke-like syndromes, early onset of dementia, seizures, delirium, etc. So dermatological plus systemic features. So what causes this multi-system disease? Well, this is a summary of the major influences that are considered to be important. So I mentioned racial groups where it's more common. Clearly genetics plays a role. It's more common in women, so clearly hormonal factors are implicated. I've mentioned photosensitivity, so environmental factors such as UV exposure are relevant. And immune dysfunction is a key component of any of these autoimmune conditions, as you've heard. Now, each of these would be a lecture in themselves. There's not time to cover them all and do it justice. I just want to touch briefly on the immune dysfunction, and this follows on from what Jason has just told you. So this would be Immunology 101, a traditional simplified view of the immune system, and in particular two of the key cellular players, so T cells and B cells, talking to each other in this lymphoid compartment of the immune system, cooperating to mount responses to trouble that's sensed by the immune system as it goes about its daily business of protecting us. And traditionally, or I suppose classically, this is bacteria and viruses. One of the key responses of that system is for the B cells to be induced to produce antibodies that are protective against the invading material or organism. And so that's shown here with the antibodies recognising a component, whole or in part, of the invader. This forms an immune complex that can then circulate in the blood, sometimes deposit in tissues, invoke an inflammatory action in that site, but overall leads to clearance of the invading stimulus. So that's a very simplified traditional view of how the immune system works. Now, in the case of lupus, where this system is clearly hyperactivated for reasons that we still don't fully understand, each of these steps in the process seems to be exaggerated. In addition, the response seems to be directed primarily at self rather than foreign invaders. So, in particular, the antibodies that form recognise self-constituents such as DNA and RNA, probably derived from the cells that are dying and getting damaged and turning over constantly within our bodies. So that is the classic hallmark of the immune response in lupus, is actually to self rather than non-self. So that's shown here in terms of the diagnostic tests that we use. These are human cells here where human serum has been added, and then the reaction visualised with this, this green colour. Normally, in your eye, we would hope that there's no reactivity whatsoever on this slide. This is a patient with lupus where antibodies are binding to components of the human cells and lighting up the cells. Similar tests can be done in the kidney. So this is the glomerulus that I showed you previously, now stained for deposition of immunoglobulin, the antibodies produced by B cells. And you can see that this glomerulus is lighting up. This kidney is jam-packed full of immunoglobulin that is going to disturb the normal function of the kidney. We have a wide variety of laboratory investigations that are done, looking at blood, looking for the cytopenias that I mentioned, looking for urinary abnormalities, but the hallmark laboratory test is for anti-nuclear antibodies. So these antibodies produced by B cells recognising essential constituents of our own cells. And this is an example here of a renal biopsy. You would see a similar appearance in biopsy of the skin. Now, having said that, I've made it sound clear-cut, but in clinical practice it's often terribly difficult. Such a multi-system disease, such a spectrum of severity, so many relatively non-specific features, it can be very challenging to make this condition, the diagnosis of this condition, it's easily missed. So how do we currently treat it? There are a variety of general measures that are relevant to everyone with lupus, such as avoiding too much sun, avoiding smoking. We think smoking has an important role in pathogenesis. Cardiovascular disease is actually the major cause for premature mortality in lupus, and mortality is increased by 2 to 3-fold in the lupus population compared to their age and sex-matched peers. So this is certainly a disease of enhanced mortality. So we look very carefully at cardiovascular risk factors. And then in terms of the more specific treatment, it depends very much on the range of clinical manifestations, whether that's localised to the skin, involves the joints, etc., or whether it's more life-threatening involvement with major organs such as the kidney or the brain. Now, most of our treatment is relatively non-specific immunosuppression with agents such as steroids, cyclophosphamide, these are cytotoxic agents, azathioprine, etc. So relatively blunt, effective, but blunt tools, relatively with a lot of side effects. So as some of you would know, that in other areas of rheumatology, such as rheumatoid arthritis, there's been enormous advances in the use of biological therapies. And these are primarily therapeutic antibodies. So this is taking the ability of the B cell to make an exquisitely specific antibody to a particular target, building on the work that was done here at WEHI by Gus and others showing that one B cell made a single antibody that was developed into therapeutic use of monoclonal antibodies. This has been used with great success in diseases such as rheumatoid arthritis. It's being tried in lupus, but progress is way behind. So an antibody called rituximab, which recognises a marker of B cells, has been used in clinical practice, sometimes seems to be useful, but in formal clinical trials has not performed so well. A growth factor for B cells called BAFF has been targeted with a different antibody. Once again, only modest benefits in the clinical trials to date. So plenty of excitement, but plenty of room for improvement. So what are we doing? Research is unpredictable, and insights come in strange ways that are often unexpected. And this is a figure from a paper published in 2003, where people took an unbiased approach, not us, these were other researchers, and they said, let's just describe what we find in lupus. Let's not start with any preconceived ideas. Let's just look at the peripheral blood cells and see which genes are turned on. This sort of approach is now much more feasible than it was in the past because of the Human Genome Project. We're now able to profile thousands of genes rather than our favourites. And so that was done in the blood of lupus patients, and this is a so-called heat map where red indicates increased expression of a gene, and these columns here in the middle are patients with lupus, and a particular pathway lighted up. And the pathway shown here on this right-hand side where normal blood cells were taken, and interferon, a cytokine, one of the mediators that cells use to talk to each other in the immune system, was added to those healthy cells, and particular genes lit up, shown here in red. The pattern was exactly the same in lupus, indicating that the same pathway was being switched on in patients with lupus, now known as the interferon gene signature, now known to correlate with disease activity. Now, the importance of that, in addition to its potential use as a diagnostic marker, was that particular cells are expert at making these interferons, and in particular, a cell called a dendritic cell. So, immunology 102. So we've enlarged the picture now so that we've got T cells talking to B cells, but we have another key player in the system, and that's a dendritic cell. This dendritic cell is equipped with specialised sensors that can recognise DNA or RNA, so nucleic acid material that may derive from microbes in the environment, but may also come from self, from our own cells and tissues, recognised by these sensors within the dendritic cell, which then produces these interferons. They feed into the activation of T cells and B cells, enhance what those cells are normally doing. The system's overactive anyway in lupus at the start, but it's now switched on permanently in an amplification loop where more of these autoantibodies are being produced. So we've been interested in the idea of trying to target this new kid on the block, I guess, the dendritic cell in lupus. And so this is work that we're doing very much in collaboration with CSL. And this started as, once again, a profiling exercise that scientists at CSL did, and they found that in looking at a whole series of blood cells, these are human blood cells along here, for expression of various markers, a few things stood out as particular markers of dendritic cells, and that's shown here as high level of expression on the y-axis here. Now, it turns out that this marker that was overexpressed in this particular subset of cells, a tiny little subset of cells, less than 1% of cells circulating in the body, was known as CD123, a receptor for a cytokine known as IL-3, related to work that was done here at Weihai in a different field. It turns out that that is very much a marker of these dendritic cells. The importance of that was that CSL had been working on CD123 in a different context, and this was in the context of leukemia. They developed a monoclonal antibody called CSL362, recognising this marker, the IL-3 receptor, otherwise known as CD123. This monoclonal antibody, with some clever molecular tweaking, was now able to deplete these CD123 positive cells and lower their numbers in the system. So this is an example of the sort of experiment that's done here, where these dendritic cells are stimulated with a nucleic acid to induce production of interferon. If you add in this antibody to CD123, you can see the production of interferons declining. I wanted to mention in passing that we're not the only group at WEHI working on lupus. Dave Tarleton, who's an expert on B cells, one of Gus's proteges, also has a very active program trying to target the effector stage of B cell development known as plasma cells, which are the B cells that actually make antibody. So the future, I think it's very bright. It's very exciting in lupus. There is a lot happening, and this slide, which you won't be able to read, but it just indicates the number of clinical trials that are registered in the system and ongoing in lupus at the moment. This first slide here shows the trials that are targeting B cells, the antibody-forming cells in particular. And this next slide shows other potential therapeutic targets, a wide variety of molecules in the immune system being targeted by various approaches. So a lot of excitement, a lot of news is going to come through in lupus. So to summarise, a fascinating disease, an incredibly heterogeneous disease, a wide spectrum of manifestations in patients, underpinned by autoimmunity and a chronic process that has a major impact on predominantly young women with lupus. There's a key role for the immune system in this disorder, and the recognition of self is altered. Current treatment is around various levels of immunosuppression, low versus high intensity, depending on the severity, relatively blunt instruments. The future is about more targeted immune interventions, the application of omics technologies, and I've described a few of those to you briefly, with the view to more personalised medicine in this incredibly heterogeneous condition. I wanted to finish by thanking a few people. Dr. Shireen Oon is a rheumatologist doing her PhD with me in the lab on this project, and we're hoping, in conjunction with CSL, to build the rationale for clinical trials of the CSL antibody. Dr. Nick Wilson is one of the senior scientists at CSL, and this has very much been a collaboration with them. We have funding from other sources that I'm very grateful to acknowledge. I've also used some slides from the American College of Rheumatology Image Bank, so thank you to them.
Thank you, Ian, for a fascinating talk. Thank you also for vindicating my statement to the audience that the collaboration with CSL, which began in 1915, is alive and well 100 years later. And isn't it fascinating to think that after so many years of standardised, semi-effective treatment for lupus, we now have this range of new treatments, and really a brave new day. Now, our last speaker tonight is Dr. Vanessa Bryant. Dr. Bryant leads the investigation of human primary immunodeficiencies in the Immunology Division of the Walter and Eliza Hall Institute. She's studying the genetic and immune changes that cause common variable immune deficiency, the most common inherited primary immunodeficiency in Australia and worldwide. Dr. Bryant works closely with clinicians at the Royal Melbourne Hospital and is currently involved in a clinical study identifying candidate genes responsible for disease in a number of families with common variable immunodeficiency. Please welcome Vanessa.
Thanks, Gus, for the introduction, and thanks to the organisers for inviting me to speak today. So I'm going to present one of the projects that we've been working on here at WEHI, investigating the genetic causes of primary immunodeficiencies. But I'll backtrack a bit, and I will start with a general introduction. So what is a primary immunodeficiency? Well, it's actually a collection of disorders, and it's based on an impaired ability to produce a normal immune response. So most of the disorders have been caused by mutations in genes, many of which, up to 70%, have been identified today, and they're involved in the development as well as the function of immune organs, cells, and molecules. Now, the World Health Organization has identified more than 200 primary immunodeficiencies, and this list expands every year. With the powerful whole genomic sequencing that we do now, we can now add to this list many unexplained susceptibilities to specific viral infections and specific bacterial infections. And one example of this is a herpes simplex infection. So for you or I, it might result in a small cold sore on our face, a mild inconvenience. With people with an UNC93 deficiency, with a mutation in UNC93 gene, it actually causes severe cerebral meningitis and death in children. So a question people often ask is, does my child have primary immunodeficiency? And the answer is probably not. We've heard from Ian and Jason about the prevalence of autoimmune diseases such as celiac disease and lupus, and primary immunodeficiencies are much more rare. They range from 1 in 50,000 to 1 in a million live births or people. So most children, most healthy children, actually get around 6 to 8, up to 10 upper respiratory tract infections per year, and this is completely normal. Kids with primary immunodeficiencies have a completely different story. These kids have a severe failure to thrive. These common household infections that cause inconvenience for you or I, a couple of days off work, actually result in repeated hospitalisation in these kids. Infections such as oral thrush for more than 1 year, deep skin abscesses, sinus infections and ear infections. These people often need intravenous antibiotics to help treat these generally common infections, and often there's a family history of primary immunodeficiencies as well. So perhaps the most famous example of a primary immunodeficiency is David Vetter, known as the bubble boy. So he had the most severe form of primary immunodeficiency, which is called SCID, or severe combined immunodeficiency, which actually is the result of a complete absence of all his immune cells. So he's missing his T cells, B cells, as well as NK cells, and so is extremely susceptible to everyday bacteria and viruses, and his parents actually constructed a bubble, a sterile environment for which he could live. So how do we treat primary immunodeficiency? And of course, the answer to this question is complicated. It depends. So in some forms, the severe forms, such as SCID, where they're completely missing their immune system, we can replace it with hematopoietic stem cell transplantation. However, this isn't an option for many primary immunodeficient patients because they have some immune cells. So these patients would either be on lifelong immunosuppression, or those few immune cells they have actually attack the transplant and they end up with graft versus host disease. And examples of these disorders include hyper-IgE syndrome, hyper-IgM syndrome, X-linked lymphoperipheral disorder, and common variable immunodeficiency. In these patients, our general approach is to replace the antibodies, either intravenously with IVIG or subcutaneously with SCIG. So IVIG is a replacement antibody therapy. It stands for intravenous immunoglobulin G. It consists of monthly infusions, so monthly hospital visits for patients that last about 3 hours. This is used primarily for antibody deficiencies, and antibody deficiencies account for approximately half of all primary immunodeficiencies. So antibodies are found circulating in our blood, in the serum and in the plasma, and every single dose of IVIG that every patient receives every month actually consists of more than 1,000 donors that have been pulled for their blood. So the antibodies are so few in the blood, we have to collect 1,000 donors just to receive a single dose of this treatment. So it's incredibly expensive, it's incredibly time consuming. It also has a huge impact on the quality of life of patients. Kids have to miss school every month, parents have to come in. It's a huge drain on our hospital system as well as the patient's life. So half of all of the IVIG usage in Australia is actually accounted for by CVID patients. And remember, this is a lifelong therapy.
So just a bit more information on what CVID is. So as I said, it stands for Common Variable Immunodeficiency. It's an incredibly rare disorder, but it's the most common of all of the immunodeficiencies in Australia, affecting approximately 1 in 66,000 Australians. It's characterised by recurring infections of the ears, eyes, sinuses, and nose, etc. And common characteristics include fatigue, abdominal pain, nausea, and diarrhoea. So how do we actually diagnose CVID? It's a diagnosis largely of exclusion of all the other primary immunodeficiencies. So it's diagnosed by what we call hypogammaglobulinemia, which really means reduced but not absent antibody levels circulating in the blood. These patients therefore have very poor vaccine responses and also therefore have incredibly variable clinical presentations. We actually now think that CVID in reality is a collection of hundreds of primary immunodeficiency disorders. It's also very difficult to diagnose in kids because it can actually mimic the immature immune system. And as an example here, I have a table showing age here, and IgG, IgA and IgM, the 3 classes of antibodies we have in our bodies. And in yellow is highlighted the cutoff levels to diagnose with CVID. And you can see these mimic basically the average immunoglobulin levels of a 3-year-old and a 1-year-old. So it's incredibly difficult to diagnose in kids. It also occurs in young adults, and because of all of these reasons, it can take up to 10 years to diagnose patients, which is an incredibly long and incredibly stressful process for many patients. A recent study even showed that a delay in diagnosis of CVID by just 1 year results in a 4% increase in the risk of mortality. So the most clearly defined primary immunodeficiencies, the ones we know most about, they're very, very rare, and these often represent the most severe cases. In these cases, we can often successfully treat patients with hematopoietic stem cell transplantation. However, for the more common primary immunodeficiencies, such as CVID, we really don't know much about them. These affect older individuals who don't necessarily have this disease from birth, and often occurs at crucial stages in life, kids during their school years and young adulthood, and therefore has a significant impact on their quality of life. So our goal is to understand the genetic causes of CVID and the sorts of impact that we think this will have. It will allow clinicians to efficiently, molecularly and accurately diagnose patients, including those with very mild symptoms. We can also screen new family members, helping with the management of disease and all of the complications. And we think it will also offer new avenues of personalised targeted medicine, and we can actually specify the specific pathway that's defective in many CVID patients and target with specific drugs. So the genetic causes of CVID are mostly unknown. So I have a list of genes. These are all of the genes that we know are mutated in CVID patients, and it's quite an impressive list. The only problem is it counts for very few patients worldwide. So we have launched a study 2 years ago now investigating the genetic causes of CVID in collaboration with clinicians at the Royal Melbourne Hospital. And our approach is to sequence the entire exome or genome of patients and identify particular candidate genes that we believe are responsible for disease and test these in the lab. Once we identify the gene, we look for a cellular phenotype and we link the function of this gene back to clinical disease to prove its disease causing and hopefully find some therapeutics. So we have currently 53 patients recruited into our study, and this includes a number of families. And I'm just going to show you some results that we've received from 2 of the families enrolled in our study that we've sent for whole exome sequencing. So the first family is this one here. This has a mum and 2 young girls, all with CVID. So this family has neutropenia, thrombocytopenia, and a number of different complications. So we sequenced the entire exome of members of this family, and we came up with a mutation in the CXCR4 gene, a chemokine receptor. And this is just to show that you can see the gene mutation shown in green. We get hits in the mum and one of the girls, but not in one of the healthy controls. So this mutation has actually been previously described before in another disorder called WHIM. So WHIM stands for warts, hypogammaglobulinemia, infections, and myelokathexis. So myelokathexis is actually the retention of neutrophils in the bone marrow. So essentially, when neutrophils are produced, they get stuck at the last stage and cannot exit to circulate and protect against bacterial infections. So basically, we have a new diagnosis based on our genetic findings. And this patient was not considered to have WHIM at all, given that they have a complete lack of warts and very mild neutropenia. But we do have some very good news. So very recently, a small molecule has been described that's commonly used in stem cell transplantation to promote neutrophils and B cells circulating in healthy people who are stem cell donors. So basically, the small molecule helps to release the neutrophils and the B cells from the bone marrow. So if we think of the bone marrow as a factory of production of immune cells, and in WHIM and our particular patients, the neutrophils and the B cells are stuck at the final step before they're approved for dispatch in the bone marrow factory. So this small molecule plerixafor specifically targets the CXCR4, and it approves the neutrophils and the B cells also for dispatch from the bone marrow, and then they can circulate and fight infection normally. So our second family consists of a young woman at RMH who has not been diagnosed with CVID, but possible CVID in evolution. She has borderline immunoglobulin levels and some mild recurrent sinus infection. Her mother and her grandmother have both been diagnosed with CVID more than 10 years ago. So we exome sequenced this family, and we found a particular gene that was mutated in the grandmother, mother, and our patient, but not any of the other healthy family members. And we believe it's a great candidate to cause CVID in this family. As it turns out, there was another group studying an extended part of this kindred. It's actually a Dutch family that was being studied by Bodo Grimbacher in the University of Freiburg in Germany. So we combined forces and pooled our resources to figure out what's going on. So this is a very large family tree, and you can see all of the patients in black have CVID, and the shaded patients here have been diagnosed with an associated specific IgA deficiency. And all of these patients carry this mutation in NF-kappa B, and none of their healthy relatives do. So we've been conducting tests in the lab to characterise this particular mutation. And you can see as an example, these are two healthy controls that carry the wild-type gene, and this is one of the patients. So she has a copy of the wild-type gene, but she also has a copy of this small, slightly truncated, broken allele as well. So we've been characterising the B cell response and the T cell response in these particular patients to actually pinpoint exactly where the defect lies and how we can possibly treat it. We've also been looking at mouse models of disease. So mice that are actually missing this gene are specifically and exquisitely susceptible to gastric cancers. So many CVID patients do get gastric cancers, but they don't tend to actually screen for these routinely, given it's an incredibly invasive procedure. So we would recommend that perhaps CVID patients can be screened for carrying NF-kappa B family mutations, and these patients particularly monitored to prevent gastric cancers. So the impact I'm showing you in just two of the families that we're studying here at WeHi, we can potentially recommend some targeted therapies, offer genetic diagnosis, and potentially prevent malignancies, other complications of CVID, and also we can apply what we know to autoimmune disorders. I haven't spoken about this today, but a quarter of CVID patients also exhibit autoimmune diseases, and we're investigating that in another arm of the study. So this is where we are today, the link between the lab and the clinic. So in the lab, we're currently focusing on efforts on whole genome sequencing patients to identify these candidate genes. and link the gene to the clinical phenotype to search for novel therapies. While next door in the clinic, they are focusing on, mainly they are having descriptive diagnoses of CVID. Patients are treated with antibody replacement therapy, and generally the symptoms are managed, a one-size-fits-all approach. Now, the way I see this heading in the future, and by the future I really mean the next 5 years, is that we will be focusing less and less on the whole genome sequencing on patients, and this will move into a standard of practice in the clinic, where most patients will be sequenced for their entire genome, identify genetic mutations and biomarkers, personalised medicines and preventative medicines can be established. Whereas in the lab, we can then shift our focus a little bit more to the rare, complex diseases that are largely ignored at the moment, discover new roles for new genes, and of course, continue the search for novel therapies. So I'd just like to acknowledge the people who contributed to this work of the greater project and some of the projects that I've spoken about today, one of which is Dr. Charlotte Slade, who's an immunologist next door at the Royal Melbourne Hospital and also a PhD student in our lab, and she'll be joining us for the panel discussion. I'd like to particularly thank the patients and their families for donating their time and their precious blood to our study. It's incredibly appreciated. We have more information about primary immunodeficiencies and our particular research that we're doing here at WeHi on this website link. And I'd just like to acknowledge the Royal Melbourne Hospital Foundation and the Bloody Long Way for supporting our research. The Bloody Long Way is an incredible association of patients, and every year they have a fundraiser where about 10 to 15 immunodeficiency patients jump on their bikes and ride from Bendigo to Eltham overnight to raise money, particularly for our research. So I'd like to thank them. Thank you.
Vanessa, thank you for a truly great talk, and congratulations on your ambitious research program and its stunning early successes. Now, I'd like the panellists to move to these ultra-comfortable chairs over here, and while they do so, I'm going to introduce one more person to you, and that's Dr. Charlotte Slade, who is going to join the panel. Dr. Slade's a clinical immunologist at the Royal Melbourne Hospital and a PhD student at the Walter and Eliza Hall Institute. She treats patients with primary immunodeficiencies and is now also undertaking research into the conditions, working with Dr. Vanessa Bryant, including a clinical study investigating CVID. And we got mics? Pardon? Yes, we're running a little bit late, so people who have to go don't hesitate to go. But you're going to miss the best part of the evening if you do. And we got mics over here, have we?
Yeah, they're all good.
Well, there's not room. But have you got mics?
We've got, we're mic'd up, yep.
Okay,
Yep.
okay. It's always difficult to get the first question, so I'm going to ask the first one. And true to what I promised, I'll make it to the first speaker. I want to ask Jason to just go on a little bit about this question of the genetic signature and the people at special risk, the people who may may have high risk of developing celiac disease. Do you see any place for very early therapy of such subjects, such as feeding them the peptides?
So it's been a really interesting few years now where we've realised that there are certain genes that put people at higher risk of celiac disease, and in fact testing for the HLA genes is now commonplace in clinical practice, and in the last decade there's been a tenfold increase in the testing by doctors for HLA genes in celiac disease. It's the most popularly requested test for genetic test in Australia. So there's a lot of awareness about the risks for celiac disease, but we don't really have the capacity to predict accurately enough yet who is at high risk versus who is at moderate or lower risk. And hopefully understanding more of the genetic markers will help us stratify that with more detail. And certainly if we can do that with accuracy, then one of the hopes for a therapy that can induce tolerance is to give it early and use it as a true kind of vaccine. So it's a completely new paradigm of a concept of using a treatment as a sort of preventative for autoimmune disease, and celiac disease could potentially be one of those where you actually prevent its onset by targeting people before they develop it. But that's something, hopefully, that will happen in the future.
Thank you. Who'd like to be next? Now, what are we going to do about mics? Would it be a good idea for people... Yeah, if you've only got one mic, it's not going to work. What we're going to do is we're going to place one mic in each aisle and ask the speakers to scramble over their neighbours and queue up. That way we'll get a whole host of questions lined up and everyone will be able to hear. So let's get this next question moving.
Okay, so...
Your mic has got to come to the aisle here.
Oh, okay.
Come on, it works at international conferences very well.
Okay, it can work here.
I love it.
Excuse me. Thank you. Excuse me. Yep.
So if you want to ask a question, start scrambling now and queue up. Good.
Great. So I had two questions. The first one is in relation to genome sequencing. There seems to be some, do you think there's some need for some regulatory change, of course, because when you get your genome sequenced, you have to declare that in life insurance in Australia at the moment. So there is actually a reason not to do genome sequencing on yourself because, you know, anything that's shown, you've got to declare it. So it may impact your, so it's interested in some comments upon that. And secondly, just in relation to the gut biome, I know I participated in a startup, a crowdsourced startup of sequencing gut biome. But when I got the results, they didn't actually seem to know. They said, well, you've got this gut biome, but we don't really understand it at the moment. We don't really know what it does. It seems to be important, but, you know, so can you tell me more? Where's that research going and tell me about it?
Great questions. I'll direct the first one to Vanessa.
Yeah, I'll take the first one. So, yes, this is an issue and it is being thought about by great minds. So there's an initiative here at WeHi, the Melbourne Genomics Project, and the idea behind this is that it is inevitable that genetic sequencing will become a part of the clinic in the future. It's just the cost-benefit ratio, all of the parameters basically spit out that it's incredibly important for patients, for physicians to have this sort of information at their fingertips. So the Melbourne Genomics Centre has set up an enormous study as a proof of principle. So they've collected entire groups of patients that have different types of disorders. They're exome sequencing, genomic sequencing those and coming out with the information. One of the things that they're actually stipulated is they're only going to look at certain parts of the immune system. All of that information is not going to be publicly available. For example, all of the patients that I look at in my exome sequencing, I don't look at, I filter out any known defects in, associations in cardiac disease and breast cancer and all of that information because that's not what we're doing. These are susceptibility genes that may or may not be proven in the lab, and we are really looking to identify novel pathways and novel genes, as well as known genes that cause CVID. And I think that's going to happen in the clinic as well. So it's going to be very directed, very targeted, and just like you receive a path report of your antibody levels, you're going to receive a report saying these are the genes that are mutated in these parts of your immune system, and this is the one gene that we think is responsible for your disease, and hopefully that we can treat. So
thanks, and we're going to ask Jason to tell us a bit more about the microbiome.
Yeah, it's a great question. I think that one of the big challenges for the field is just the huge complexity of the microbiome. So we know there are thousands of species of different bacteria in the colon and billions of bacteria. So one statistic says there's more bacteria in your colon than there are cells in your body or stars in the Milky Way galaxy. It's a very complex environment. And so the tools to understand that are only really starting to be developed now. We know that there's, in celiac disease, for instance, there's epidemiological data, so studies from population projects which look at, for instance, the rate of caesarean section, and children born by caesarean section seem to have a higher rate of celiac disease, and the theory is that children born by caesarean section don't get exposed to the mother's bowel flora during the birth process. And so there's these kinds of little tantalising hints that there's differences in the hygiene hypothesis and differences in the rate of disease between industrialised and less developed countries also supports these differences. But I think that really, it's a good question. I think it's really in the research domain at the moment. There are groups trying to capitalise on the area and will sell this procedure and charge you for getting your faeces sort of profiled, but the results really, I don't think we can apply in clinical practice. And I have some patients who bring in printouts of, all of the bacterial species that have been profiled and say, what does this mean, and do I need to be on antibiotics? And really, it doesn't really mean anything at the present time.
You'll be interested to hear this is an area that the Gates Foundation is supporting very strongly and with very great difficulty. As Jason said, it's a tough, tough area. It's going to be important. We just don't know enough about it yet. You'll be next.
Hi. I was diagnosed with chronic neutropenia when I was 2 years old, and I've been on the GCSF injections for about 17 years now. So I was just kind of wondering, have you got any other treatments that you're looking into for the future? And we've never really discovered where it came from or how it popped up. We think there might have been a great aunt that had something similar, but we've always been really curious of kind of where it's come from or why it's popped up. So just, I don't know, to get a bit more information on that would be helpful, I guess.
I'm going to direct that question to Charlotte and also give her the opportunity to say anything she wants to us.
I'll try to say something helpful. Thanks for your question. It would be interesting to talk to you about your particular case, perhaps in a more private setting about your details, but we run a clinical genetics an immunogenetics clinic at Royal Melbourne Hospital where we could talk to you about particular genes that might be involved and go through your family history. At the moment, there aren't any particularly specific therapies for chronic neutropenia other than the GCSF that you're already on. Although, as Vanessa just mentioned about our family with WHIM syndrome or CVID with the CXCR4 mutation, for further testing down the track, we may fall upon some targeted therapy that we could use in particular cases, such as you, if we found a particular genetic cause, and that's what we hope to do in the future. So you can get referred to the genetics clinic at Royal Melbourne Hospital.
And we've got a question over here now.
Hi. I have Sjogren's syndrome and lupus, SLE, lupus nephritis. I'm just wondering what the future is with steroids and if they're going to develop steroids with lesser side effects because they're not ideal for long-term use.
A really beautiful question for Ian.
So, yeah, Sjogren's syndrome is a very common association of a variety of conditions, including lupus and rheumatoid arthritis. So for those who aren't aware, it's where the immune system attacks the lacrimal and salivary glands and leads to destruction of those tissues, and patients develop dry eyes and dry mouth, amongst a range of other possible manifestations. So in terms of so it's kind of part and parcel of the same territory. In terms of your question about steroids, I guess it's been a holy grail of steroid research for over 50 years to try and come up with less toxic steroids. They certainly cause damage over time, and I mentioned just in passing the accelerated atherosclerosis that we see, for example, in lupus, which is the main reason for premature mortality or loss of life in people with lupus. A big contributor is undoubtedly the chronic use of steroids, the problems such as glucose intolerance and diabetes, altered muscle physiology, etc., etc. That's making us incredibly vigilant about the cardiovascular risk factors that I mentioned. So weight, exercise, smoking, blood pressure, all of those normal things we try to control very, very tightly now. But a big hope in all of the research that I talked about would be to substitute the sort of agents that are under development increasingly to take the place of steroids. And there are studies now in renal lupus that have no steroids whatsoever in the protocols. So they use the monoclonal antibodies that I've talked about and some of the newer immunosuppressive drugs such as mycophenolate with no steroids. Steroids have, as you would be aware, have been the mainstay of treatment for some of the serious organ life-threatening complications of lupus. So it's changing, and the hope is that we'll have alternatives to steroids and we'll be able to do more effectively what we always try to do, which is to use steroids at the lowest possible dose for the shortest possible time.
Thank you. We've got time for just two more. One here and one here.
I have two questions. I personally have systemic lupus, and I also have the gene for celiac. And so I was just wondering if it would be sensible for me to go on a celiac diet. And,
Jason, sorry.
And
We'll have to take one question at a time. We'll get Jason to answer that one.
So one of the current gene tests for celiac disease, the HLA DQ2 and DQ8 test, is very good when it's negative because it has what we call excellent negative predictive value. In other words, if you don't have that gene, we can say celiac disease is extremely unlikely. About 99.6% of people with celiac disease have that gene. But in the general population, about 40 to 50% also have that. So therefore, the presence of the gene doesn't necessarily predict celiac disease is going to happen in you. So you have a risk factor having lupus, you have genetic susceptibility, but it doesn't necessarily say you have it. But I would recommend that in these sorts of cases, speaking to your doctor about whether screening with the simple blood test for celiac disease would be the way to go. And we would never recommend starting a gluten-free diet on the basis of a gene test. We would always want the definitive way to diagnose celiac disease, which currently still remains demonstrating the damage in the small bowel with the gastroscopy.
Question number two, briefly.
And, the question number two is, how does a family go about getting a screening for CVID if their child has chronic ear infection for many, many years?
Shall I take that one?
Charlotte.
So it's usually up to clinical judgment. I'm not a paediatrician, so I don't actually look after children, but as Vanessa pointed out, children get frequent infections, particularly going to childcare and school. If the clinician who's looking after that child thought that it was out of the ordinary or there was particular concern, then it's usually done with a blood test and testing the antibody levels in the serum, which in very young children can be low, and it's part of the immune system developing that by a certain age they reach levels that are protective, but it can be very difficult in children under the age of 4 to diagnose CVID. In fact, we don't diagnose it under the age of 4. We can certainly suspect it, but by definition it doesn't get diagnosed before 4 years of age.
Thank you. And our very last question.
One common feature of the immune disorders discussed tonight is fatigue. And I was just wondering, given that fatigue is probably the most disabling symptom of all, I was wondering if research has shown any light, given any insight into the cause of the fatigue. Does it go back to mitochondrial dysfunction, production of ATP, or is it in some other area?
A very tough question, which I'll direct to Ian.
So it's certainly a very common feature of lupus, and in fact is probably the most common feature of that patients complain of. So is poorly understood and probably multifactorial in causation. So there are different schools of thought that it's some sort of low-grade inflammatory process that may be spilling over into the brain. There may be antibodies able to cross from the circulation into the brain that interfere with normal neurotransmission. That's one theory. But of course, we have to remember the impact that illnesses like lupus, in fact, any chronic illness, has on a person's entire life. So very commonly people are struggling with other aspects of their life, whether it's the ability to work, care for a family, earn an income, get to doctor's appointments, take medications. A whole lot of things really start to happen in the life of a person with a condition such as lupus. So it's probably multifactorial. So it's probably one of the hardest things that we find to completely remove from a person's life with treatment. But we do find that it definitely improves with effective treatment of the lupus. But very important not to overlook the other potentially confounding features such as depression, lifestyle, quality of life issues that might be poor sleep that might be contributing.
Well, I'm really, really sorry to have to curtail this fascinating conversation, but I do have a solution. We can continue it outside. I want to thank the panellists for their valuable contribution. I want to thank this large audience of guests for attending. I do ask you to fill in your feedback form and hand it to staff as soon as you can. And I'd like everyone now to come and join us for some refreshments outside. If you'd actually exit this Davis auditorium, including the speakers, so rather than trapping the speakers in that little corner, let them get away too. We'll continue the conversation outside, and thank you very much, everybody, for a really great evening.